Welcome to today's webinar by the Paediatric Renal Nutrition Task Force, hosted by VitaFlow, titled The Dietary Management of Calcium and Phosphate in Children with CKD, Stages 2 to 5 and on dialysis. My name is Lucy Evans and I work as a Global Marketing Manager at VitaFlow International Limited. I'm also a dietitian by background. This webinar is the third in a series from the Paediatric Renal Nutrition Task Force, which will run throughout 2021. The paper which is referred to in today's session, titled The Dietary Management of Calcium and Phosphate in Children with CKD, Stages 2 to 5 and on dialysis, is published in Paediatric Nephrology, and a link to this paper has been posted in the chat box for you to access. A link to the paper can also be found on both the VitaFlow VIA website and the European Society of Paediatric Nephrology, or ESPN website. The paper is available via open access. This webinar is intended for healthcare professionals only. The webinar will last approximately 1 hour and 30 minutes, which includes dedicated time for a question and answer session in the last part of the webinar. If you would like to ask a question, please use the question feature on your GoToWebinar toolbar. All questions will be screened, with as many questions as possible being answered by the speakers at the end of the presentation. A practical guide and case study will be discussed during the webinar. You will find the practical guide in the handout section of the toolbar. This can be downloaded for you to use, and you can also access your certificate of attendance here. The webinar is being recorded and will be available on the VitaFlow VIA website in approximately 2 weeks. The views herein are of the presenters and do not necessarily represent VitaFlow's views. The material herein is accurate as of the date presented and is for educational purposes only and not intended as a substitute for medical advice. The learning outcomes for the session are documented on the next slide. So without further delay, let me introduce our speakers for today's webinar. VitaFlow is delighted to introduce Dr. Ruxana Shroff, Dr. Pearl Pugh, Louise McAllister, who will be discussing the clinical practice recommendations and their implementation in clinical practice with you. I'm also delighted to introduce Vanessa Shaw, who will be chairing today's session. So Vanessa is an honorary senior lecturer at UCL Great Ormond Street Institute of Child Health, University College London, UK. Vanessa was head of dietetics at Great Ormond Street Hospital for Children in London until 2017. She was awarded a national honour, an MBE, for services to children's healthcare. Vanessa is a reviewer for Paediatric Nephrology and the Journal of Renal Nutrition and co-chair of the Paediatric Renal Nutrition Task Force. Vanessa is committed to the education and training of dietitians, and this is evidenced through the establishment of the unique Master's Programme in Paediatric Dietetics, a partnership degree between the British Dietetic Association and the University of Plymouth, where she was an honorary associate professor until January 2021. Vanessa was made a fellow of the British Dietetic Association in 2007. Vanessa is the editor of Clinical Paediatric Dietetics, the seminal text for paediatric dietitians in the UK and overseas, and it's now in its 5th edition. So without further delay, I will pass the mic to Vanessa, who will start this webinar with an overview of the excellent work of the task force to date. Thanks, Vanessa.
Thank you for that introduction, Lucy. I'm just going to give a very brief introduction to the Paediatric Renal Nutrition Task Force for those of you who haven't come across us before. As you can see, we're a group of 7 paediatric nephrologists and 7 paediatric renal dietitians from across Europe and North America. Now, the task force was established in November 2017, and what we felt we needed to address was the inconsistencies in the nutritional management of children with CKD globally, and also to acknowledge that the importance of nutrition in patient care is often overlooked or not included in medical education. And compounding this as well is that even dietitians in tertiary renal centres don't often have an adequately trained paediatric dietitian. So our vision was to ensure best practice in nutritional management of children with kidney diseases by formulating clinical practice recommendations to enable best practice. And we wanted to provide not only education and training resources for healthcare professionals, but we also wanted to create resources, both written resources and digital resources, to offer practical support to the children we look after and their families. The other aspect of our work is to promote research so that we can expand the evidence-based nutritional intervention in pediatric kidney disease. And as you know, the evidence base at the moment is still fairly poor. And just to say, to kick off this research aspect, we've just submitted our first grant application for our first nutrition research project. Our work's open and transparent. We work inclusively with external experts, and that's very well illustrated today by including Louise McAllister and Pearl Pugh, who've been invited to join the task force to give us their particular skills in their specialist areas. So you can see that we have a number of clinical practice recommendations that we've already had published. These are all available through open access online, and we've given the DOIs there for you. The first practice recommendation on assessment of nutritional status is in broad support of all children with a range of kidney diseases. We then have a suite of practice recommendations that are particularly targeted at children with CKD stages 2 to 5D. And these have all been supported by webinars. If you happen to have missed the first 2 webinars, then they are available, as Lucy mentioned earlier, on the VitaFlow website. And today's webinar will equally be recorded, so you can rejoin it later if you wish. We have a paper accepted for publication, and this is on obesity and metabolic syndrome in CKD 2 to 5D and post-transplant. And our current work under preparation is nutritional management of AKI. Now, both of these CPRs will be presented at the VitaFlow International Nutrition Conference on the 17th of November this year, and you'll get details about how to register for this at a later date. We've also got 2 new working groups established. We've listened to what you've been saying to us at the end of the previous 2 webinars. And so our 2 new working groups are addressing topics that you've suggested to us. One on vitamins, minerals and trace elements in CKD, and the other the role of dietary fibre in CKD. So now on to our topic for today. It gives me great pleasure to introduce Dr. Rukhsana Shroff. Rukhsana is a consultant at Great Ormond Street Children's Hospital, and she's also an associate professor at UCL. Rukhsana is a prolific researcher with an excess of 250 original articles, reviews and editorials, and she serves on the editorial board of several journals and is a member of international guideline committees, KDIGO, ESPEN and NICE in the UK. Rukhsana's research focuses on bone and cardiovascular disease and CKD, and with this in mind, she's in an excellent position to introduce the background to our CPR for the management of calcium and phosphate. Rukhsana.
So thank you for the introduction, and welcome everyone to our webinar today. So I'm going to give you an overview on chronic kidney disease, mineral and bone disorder, and then we go on to the dietetic management that will be very expertly handled by Louise and Pearl. So I'll talk to you about bone disease in CKD, the clinical studies, biomarkers and bone histology findings, a little bit about cardiovascular disease and the CKD-MBD spectrum. I'll very briefly mention guidelines on CKD-MBD management, and as you will all know, there have been recent guidelines from KDIGO, from the UK National Institute of Health and Care Excellence, from the European Society of Pediatric Nephrology, and then of course our very own Pediatric Renal Nutrition Task Force. As this is going to be largely focused on dietetic management, I will not be discussing the PTH and calcimimetic management, nor the vitamin D guidelines, but I believe this will be the subject of a future webinar. So, in chronic kidney disease, we have this very fine balance we need to achieve between too little calcium that is associated with bone pain, rickets, osteopenia, and fractures, and can cause the most debilitating bone disease with a very high morbidity for patients. On the other hand, we have too much calcium, which can deposit in the soft tissues and cause vascular calcification, and is of course associated with a very high cardiovascular mortality that we see in our patients. And this spectrum from bone and cardiovascular is together called chronic kidney disease, mineral and bone disorder, or CKD-MBD. It is indeed a tightrope you walk between preventing bone disease and achieving adequate and preventing cardiovascular disease. And we look at a few aspects of how one can hopefully try and get the balance right here. So an important message you'll hear through my talk is that growing children need calcium. And if we look at this graph for a minute, as one goes across the ages from birth to 100 years, you see that the amount of calcium accumulation in the skeleton on the y-axis here goes from as little as just 25 grams at birth to as much as 1.5 kilograms in an adult male. And this calcium accrual, of course, happens in the bones in the first 2 or 3 decades of life. And by about 30 years of age, we achieve what is called the peak bone mass. And you cannot have more calcium accumulated in the skeleton beyond this point. So then there's a slow decline in the amount of skeletal calcium. And of course, this is associated with osteoporosis, which occurs at varying rates in males and females. So even in healthy children, a low bone mineral density is associated with fracture risk. And if we look at this, with the same graph of peak bone mass, if one does not achieve this, and there's even a 10% decline in the peak bone mass, this is associated with a 50% increase in fracture risk after menopause. And therefore, our patients, our CKD boys and girls, are in a similar situation. Their bones do need to mineralize at this crucial young age. Now, there's the reason for this stress on bone mineralization is because there's a very high incidence of hip fractures as the GFR declines. So these different colored lines here show you patients with different GFR going from the general population in black, where there's a very clear age-associated increase in fracture risk, to our patients on dialysis in the blue line here. And you see that dialysis patients have an extremely high risk of fractures even at a young age. And in fact, this is a 4 to 5-fold higher risk of hip fractures in the dialysis population. What is as important or more important is the mortality associated with this. The 1-year hip fracture mortality in the general population is 20%, increasing to 50% in dialysis patients. And this is a huge burden of morbidity with fractures, but also with bone pain and deformities as well. Now, the previous slide was all about adults, but what about children? So in this excellent study from the US, they have looked at over 500 children with mild to moderate CKD. And in fact, 83%, the majority of them were in early stages 1 to 3 of CKD. And over a 4-year follow-up, they found that there was a 2 to 3-fold higher fracture risk in boys and girls compared to their healthy peers. So the fracture risk starts at a young age. You don't have to wait till late adulthood for this. And looking at risk factors for fracture, they found that there was an increased risk or an increased hazard ratio of fractures associated with a pubertal stage, with the height, with the growth or growth velocity even, and with a low GFR and walking difficulty. But there was one factor which was protective, and that was the phosphate binder. So the phosphate binder is the only factor below this line suggesting a protective effect in this cohort. And then, of course, PTH itself must be stressed because a high PTH level associated with a higher fracture risk. Now, looking at these modifiable risk factors, including serum phosphate, the binders, and the PTH, let us look at phosphate risk and fractures, and how we manage the different components of mineral bone disorder. So this is hot off the press. Just this week at the ERA-EDTA meeting, this excellent study from the Cosmos group in Spain came through. And here they looked at over 6,000 patients across 200 sites in Europe who are all on hemodialysis. And they found that no matter which way they looked at the risk association, a high phosphate level was associated with a high fracture risk. 4% of their cohort had fractures in this very short 2-year follow-up period. And the phosphate levels above 6.1 milligrams per deciliter were independently and consistently associated with a high fracture risk. So everything points to high phosphate and high PTH as well being fracture risks. So looking at how we can evaluate mineral bone disease and then how we manage this. So evaluating MBD or mineral bone disease must look at, and the treatments for it must be based on serial assessments of calcium, phosphate, PTH, and alkaline phosphatase and vitamin D considered together following trends and levels. And this is really, these two aspects are really important as stressed by all of these guidelines here. You cannot look at any one of these in isolation, and you must look at the trends and the levels. What is not helpful is doing routine DEXA bone scans. Now, some centers look at the bone mineral density and monitor it, but radiological changes are very slow to happen. A 2D image cannot distinguish cortical and trabecular bone. There's no evaluation of bone geometry or architecture and mineralization from a DEXA scan. And of course, in children with poor growth, it would systematically underestimate the bone mineral density. And therefore, DEXAs are not useful. We went on to investigate this further, and my PhD fellow looked at a cohort of 103 children and young adults and looked at routine DEXA hips, which had no correlation with any of the bone biomarkers, but a more sophisticated form of radiological testing, which is called the peripheral quantitative CT scan, actually takes a 3D image of the bone, distinguishes the outer cortex from the inner trabeculum, and allows us to determine the effects of mineral bone markers on this. So looking at the cortical bone mineral density, which is out here, we looked at the biomarkers that would correlate with it. And we saw that there was an inverse correlation with PTH and a linear correlation with calcium and inverse with alkaline phosphatase. And these three markers together would predict over half of the changes in the cortical BMD. Now, the cortical bone mineral density is what keeps the bone strong and well mineralized, and of course, strong bones don't fracture. And therefore, avoiding high PTH levels and maintaining enough calcium is crucial for these patients. So, having said all of this and having said how important phosphate is, what is the actual reality out there? And the reality, as captured in this International Pediatric Peritoneal Dialysis Network, which looks at over 900 children from several different countries, saw that in the overall cohort, 45% of all pediatric patients on PD had hyperphosphatemia. So high phosphate was widely prevalent, but when we split this into different age ranges, in the youngest children, the prevalence of hyperphosphatemia was relatively lower compared to the teenagers, where 80% of them had hyperphosphatemia. Now, of course, nothing biological changes at this age. In teenage years, it's the diet, it's the adherence, and it's perhaps the lifestyle that we need to look into in more detail as well. Moving on, the phosphate exposure over time is extremely important. So it is not a single measure of phosphate, which could be high or low. It is looking at the exposure over a period of time, including the peaks and troughs in phosphate level over time. And this very nice study, which is performed in the adult dialysis population of, I think this is 90,000 adults on dialysis around the world, they have seen that when they look at this area under the curves of the shaded parts, for example, for different patients, you see that the phosphate exposure becomes meaningful. And here they go on to look at the risk factors of a high phosphate exposure over a 6-month period, comparing it to the hazard of adverse cardiovascular events, major adverse cardiovascular events, cardiovascular death, all-cause mortality, and non-cardiovascular death. And they see the pink bars here, which indicates a persistently high area under the curve more than 2. So persistently high exposure to phosphate illustrates that the risk is extremely high when you're exposed over a long period of time. Similarly, let's look at PTH now. So the same cohort from the International Pediatric Peritoneal Dialysis Network looked at the percentage of patients who had a high calcium and phosphate, as well as different sorts of bone problems from osteodystrophy, limb deformities, osteopenia, tissue calcification, and bone pain. And they looked at the PTH levels compared to these. So what they saw was that if one grades sort of the PTH levels against the severity of complications, you get this kind of J-shaped curve. So what this implies is that at very low levels of PTH, there's a risk of hypercalcemia, which of course is bad. At very high levels of PTH above 300, you can have clinical and radiological symptoms. Clinical symptoms being bone pain, and over time deformities, and radiological symptoms being bone demineralization. When PTH levels are above 500, there's in fact a reduced longitudinal growth or reduced height. And therefore, the optimal PTH level most likely is in this range of 100 to 300 picograms per mil, which would roughly translate to approximately 2 to 3 times the upper limit of normal. And that is what we certainly aim to do in my center. So we've talked about phosphate and PTH, but in the trajectory of GFR decline and the changes that happen as GFR declines, an increased phosphate load becomes apparent pretty early on. However, hyperphosphatemia per se manifests only much later. And before you have overt hyperphosphatemia, there are already changes happening in the bone. And one of the early markers to go up is FGF23 or fibroblast growth factor 23. Now, this is a very sensitive measure of hyperphosphatemia, and the high FGF23, at least early on, tries to help the body get rid of excess phosphate, but it can be beneficial only to a limit. And therefore, the concept of managing phosphate load, and particularly the dietary phosphate control, must begin pretty early on in CKD. So I mentioned the fibroblast growth factor 23. It also has this molecule called clotho, which is the tissue level receptor for it. And FGF23 is produced in the bone, but it has an effect on all these different organ systems, including the heart and the brain. And there are many topics now on studies now on high FGF and cognitive dysfunction. We know it can cause left ventricular hypertrophy, and this is perhaps a marker that is going to gain increased prominence in the future and may be something that we measure in routine practice. So we talked about the biomarkers in the serum, but what actually happens at the bone level? So here, again, using this CT scan called the tibial peripheral quantitative CT scan, this group performed a cross-sectional study of 170 patients and in CKD stages 2 to 5D. And what they found was that a high calcium and a high vitamin D were beneficial and had a good positive effect on bone mineral density, whereas 1,25-dihydroxy-D and PTH had an inverse effect, and high levels of PTH or 125 vitamin D had an adverse effect on bone mineral density. Looking on at the longitudinal follow-up in the same cohort, it was seen that after 12 months, a large number, in about 89% of patients they followed up, there was an overall decline in the cortical bone mineral density, and the decline was associated with a higher baseline 125 dihydroxyvitamin D level and an increased change or increase in PTH over time. And these two were the detrimental things. The protective factor was the calcium, and a higher calcium was associated with a higher cortical bone mineral density. And this was particularly seen in growing children. Now, bone mineral density measured by the CT scan is not just another radiological measure. It very carefully correlates with a fracture risk. And one standard deviation decrease in bone mineral density was in fact associated with a twofold increase in fracture risk, implying that this is a very sensitive measure and these biomarkers that affect it must be carefully managed. Okay, so looking at bone biopsies. Now, bone biopsies in children have shown increased bone mineralization even at very early stages of CKD 2 to 4. And in this young cohort of children, they found mineralization defects starting in CKD stage 2 and increasing dramatically by CKD 3 and 4, so that the mineralization defects increase from prevalence of 30% up to 80% as CKD advances. And of course, I'm sure you've guessed it by now, the risk factors for this are a low calcium and a high PTH. So having talked about bone, and a very, very simple message, bone needs calcium. It does not like too much PTH, and it does not like too much hyperphosphatemia. But what about the cardiovascular system? And we know that there can be calcification within the heart as well as extraosseous calcification in the soft tissues. And this cardiovascular coronary calcification is associated with an increased mortality as high as 30% in young people on dialysis. This risk of heart failure does not go away after transplant. And so the damage accrued during the years of dialysis has to be prevented to have a good outcome after transplantation. So we have looked at a number of surrogate measures of cardiovascular disease, and we measure the intermediate thickness, the pulse wave velocity, and the coronary calcification on a CT scan. And in a range of studies from around the world, although the numbers are small in each study, the message is very, very clear. A long dialysis duration is bad for the vascular measures, but also the preventable factors, the high phosphate, the high PTH, the high vitamin D dose is also detrimental. And in fact, phosphate levels are linked not just to calcification, but the progression of calcification over time. And as you go from an initial to a follow-up scan, higher calcium is associated with more calcification in the coronary vessels. And at least these two studies have shown this factor now. So we looked at an arterial biopsy model to actually look for evidence of calcification in the blood vessels themselves. And removing these blood vessels at transplantation, we measured the actual calcium load in vessels in healthy controls in the pre-dialysis CKD and the dialysis patients. And you see an exponential increase in dialysis patients with excessive calcification there. What we also did was detailed histology, looking at calcium deposition here within the vessel wall. And on a very detailed microscopy and histology assessment, we found that the architecture of the vessel, comparing these pre-dialysis vessels to dialysis vessels, you see a complete derangement in architecture, as well as calcification using multiple different modes. So excess calcium, although good for the bone, is bad for the vessel. And we have to somehow find that balance. Also, the process happening within the vessels is actually very similar to bone. So what this implies is it's not just a passive dumping of calcium within the vessel. It's not like the lime scale that forms in your kettle. It's in fact an active process of mineralization within the vessel wall. And these mineralized plaques in the vessel are very similar to the bone as well. Now, do the bone and vessel, does it make a difference that the bone might be demineralizing and the vessels may be calcifying? And yes, perhaps there is an association there. And in this study that comes from an adult cohort on hemodialysis, they compare the DEXA scans, just dividing the patients into non-osteoporotic and osteoporotic in different age categories. And they see that in each age group, those who had more osteoporosis, like loss or bone demineralization, had more calcium deposition in their vessels. And the bone demineralization is a significant predictor of the presence and the progression of coronary calcification. So we've discussed a lot about the mineral bone disease, and very clearly high phosphate is bad. You need adequate but not very high calcium. And these guidelines from KDIGO, the European Society of Pediatric Nephrology, and NICE all pretty much bring out the same message. And just to summarize it in a few words, control hyperphosphatemia and avoid hypo or hypercalcemia. And of course, our dietitians are going to tell you a lot more about controlling hyperphosphatemia and calcium management in our patients. Now, we've talked a lot about biomarkers, but no patient ever comes to me and says, "Doctor, is my PTH good?" What they want to know is how they feel. And in this wonderful study called the SONG Kids Initiative, the Standardized Outcomes in Nephrology initiative, they've asked patients and their caregivers to tell us what the core outcome or the most important things that matter to them, going in sort of peripheral circles of most to less important. And you will see that life participation is the single most important thing our patients want. They want to be normal, just like their friends. But equally, in the second group, bone health and cardiovascular health feature as very prominent factors that are important to our patients. And of course, by preserving good bone health, you prevent the fractures, the bone pain, the deformities, and that goes a long way in helping our children be normal. So with this, I'll conclude to say low calcium levels are associated with bone demineralization, particularly in growing children. Vascular calcification is prevalent in dialysis patients and associated with high calcium and phosphate levels. And a simultaneous study of bone and vessels is required to determine the optimal requirements of calcium. So guidelines have suggested phosphate lowering and keeping serum calcium in the normal range in children with CKD. Now, what we will focus on next is this paper we have produced as the Pediatric Nutrition Task Force, looking at the dietary management of calcium and phosphate in children with CKD and on dialysis. I'm going to show you just one snapshot of all the recommendations we put together. Clearly, you cannot read this, but you don't need to, because Louise and Pearl are going to take you through this in a lot of detail now. The paper is available as open access, and we will be going through all these different guidelines and discussing why we said what we said, but more importantly, how you practically implement this. So thank you all very much, and I'm going to hand over to Vanessa to introduce our dietitians.
Thank you very much, Rakshana, for that excellent comprehensive background, which has prompted the need for our dietary recommendations of dietary management of calcium and phosphate. Now, our next two speakers have been particularly invited to the task force for their expertise in calcium and phosphate. Louise is a well-experienced paediatric renal dietitian who's been working at Great Ormond Street Hospital for many years, 19 years in paediatric nephrology. She regularly presents nationally and internationally on nutrition, and she has contributed to the chapter on paediatric kidney disease in the 5th edition of clinical pediatric dietetics. Pearl is also very long experience in pediatric nephrology, and she also has an advanced practitioner role. She's completed her PhD in health sciences in 2020 at the University of Nottingham. Her research is focused on developing dietary phosphate intervention in children with early stage chronic kidney disease in order to delay disease progression. So Louise and Pearl will now take you through the practical guides and guides that we've produced for families so that you can get a very practical aspect of how to manage these two very important minerals. Louise.
Good afternoon. Well, thank you very much for this invitation to present part of this webinar today. And my plan is to give you the background to the development of some of these statements that made the clinical practice recommendations. In particular, I want to look at the dietary sources of calcium and phosphate, how to assess calcium and phosphate intake in clinical practice, and also to explain the novel term suggested dietary intake, which has been developed by the task force and against which we could evaluate the adequacy of diet. I'm then going to move on to the case study, the first part of this, which we really hope will illustrate the use of some of the practical tools that have been developed since the publication of the clinical practice recommendation in 2019. So the first question that was the CPR hoped to answer was, what are the main dietary sources of calcium and phosphate for an infant, child and adolescents? And clearly in infancy, we're looking at breast or human milk or an infant formula being the source of calcium. But detailed information at a population level on the main dietary sources of calcium beyond infancy is not widely available. So we referred to the UK National Diet and Nutrition Survey, which is a cross-sectional survey of the population, a representative sample of the population from 18 months onwards. And we hope to be able to establish what the relative contribution was of different foods to the dietary calcium and phosphate intake in children. So looking at the information for calcium first, this table here is showing the food groups on the left and the age groups moving across to the right, increasing age groups. And the two pink shaded boxes will show you the foods that mainly contribute towards calcium intake throughout childhood. And you can see that these are milk and milk products, which include milk, cheese and yogurts, and cereal products or grains. So things like rice, but also things that are made from grains, such as bread and biscuits and of course flour. And if you look at some of the figures that are quoted here, in the very young children, 70% of their calcium intake is from milk and milk products. But as you move across the table, you'll see this gradually declines as we approach, say, the age of 18. Cereal products are fairly consistent up to about the age of 7, and then there's a slight increase in their contribution. So we did feel quite reassured that there was some supporting evidence for the data that was shown from the National Diet and Nutrition Survey when we did a piece of work at Great Ormond Street that was published last year, where we had a look at the foods that were contributing towards calcium intake in our chronic kidney disease population, but also in our control group. And that's what's shown in the pie chart here. And if you have a look at the figures of dairy, which are like our milk and milk products, and of cereals, you can see that they similarly provide about 80% of the calcium intake. So we do feel that quoting the National Diet and Nutrition Survey seems to be pretty accurate. Now, what this doesn't tell you, this data, is anything about food fortification. And there's an increasing range of foods that are now fortified with calcium. So you'll see on your shelves things like orange juice, tofu, breakfast cereals, and some drinks, even some special waters are coming out that are fortified with calcium. And these aren't reflected in assessments such as I'm showing here or in food composition tables. But what we really want to know is how much is available to the body, so how much is absorbed. And as you can see from the next bullet point here, the range of absorption is so wide. So we might quote that 30% of dietary calcium is absorbed, but this can range even up to 80%. And it depends on the sources. So foods that are high in oxalates, like rhubarb and spinach, the calcium there wouldn't be that well absorbed because the oxalate binds it in the gut, making it unavailable for absorption. And similarly, foods that are high in phytates, some of the beans and pulses and nuts, they also won't have their calcium so available for absorption. The amount that you actually take in affects absorption. So your higher your calcium intake, the lower percentage absorption. The vitamin D status can affect that, and age. So when you look at infants, they may well have an absorption of something like 40 or 60% of the calcium intake from a formula milk or breast milk respectively. But when you look at an older person, it might be that they're only absorbing 15% of their calcium from their diet. So we then went on to look at similar data for phosphate, and I'm just going to show that here. And looking across the age groups, you'll see that actually we have the same two groups. So we have the cereal and cereal products and the milk and milk products, which are all providing calcium intake here. And we also have a third group, which are the meat and meat products, which certainly for the older children are providing very similar amounts of phosphate in the diet. Now, the contribution of dairy foods and of cereal to both calcium and phosphate intake are quite eloquently shown here, I would say, in that this was our research, where when we had a look at the dietary phosphate and calcium intake in our chronic kidney disease population as percentage of theoretical requirements from the UK, we found that there was quite a close correlation between them in our children. So looking in more detail at dietary phosphate, phosphate is in two forms. So organic, or those that are naturally occurring. So that is in things like egg, but also in things like meat and milk. And that would occur organically bound in these foods, but also inorganic phosphate. And by that, we're looking at phosphate additives that are added to, during food processing. And they might be there as raising agents or to extend shelf life or to improve colour, moisture, flavour. They have multiple roles. And the reason that we are interested in both forms of phosphate is because the inorganic phosphate can be widely present in food and can increase phosphate intake by over 50%. And the worry is that they have very different bioavailability. So whereas Dr. Schroff was talking about the concern about phosphate, if we have a lot of phosphate additives, they are very bioavailable. So 100% may well be absorbed, as opposed to organic phosphate, where the range is lower. So we have 30 to 70%, with the lowest absorption being from those of vegetable origin. The other point about phosphate is that we really can't rely on composition tables, and manufacturers aren't obliged to state the phosphate content of food, and databases or assessment packages will not have an accurate reflection of the amount of phosphate additives that are present there. There is terms that can be looked at on food labels, suggesting a range of phosphates additives that are present in foods. So you can see here phosphoric acid, sodium phosphate, all of these will contain phosphate additives. In addition, you've got the shaded areas here, which are starch-based phosphates, which perhaps have a lower amount of phosphate additives in them. And also they aren't necessarily declared on a food label. So many families are just taught to look for the term phos in an ingredient label to suggest that a food could contain phosphate additives. There is also an international numbering system for additives, and within Europe, those that have been adopted to be suitable for putting into food are given an E number, and so one might well teach families to look for those on an ingredient label as well. So in our CPR, what we said was that the main sources of calcium are milk and milk products, but that foods could be fortified with calcium and that would increase their contribution, and that the main dietary sources of phosphate are milk, cereals and meat, and the inorganic phosphate from processed foods also can have a significant contribution. So the next question was about dietary assessment. How do we assess how much calcium and phosphate these children are having? Well, we had to look at this in detail in our working group and looked at the usual methods, which are like dietary history and recall, either of a typical 24-hour period or the previous 24-hour periods. But they do have problems associated with them in that families don't necessarily always even remember what they ate the night before, and it's quite time consuming to go through a whole 24-hour period. Theoretically, a more accurate assessment would be to have a food diary from the families, but in practice, these are quite difficult to complete, and they do rely on literacy skills. And also, not surprisingly, the families will often record what they think you want them to have eaten rather than what they actually eat. And then food frequency questionnaires are really only suitable for research, because to actually accurately reflect somebody's intake, you have to include a lot of food items, and that then becomes quite difficult for them to complete and is quite time consuming. So as part of our CPR, we made the statement that we suggest that in chronic kidney disease and healthy children, that the diet history of a typical 24-hour period is the best way to identify the sources of calcium and phosphate and the phosphate additives. You could use a 3-day diet diary, and that may be more helpful when you need more information, particularly if you're going to try and calculate intake, but that you shouldn't just rely on the intake from diet. You must take into account other sources of calcium and phosphate, including the calcium from phosphate binders and other medications. Now, when we started working on this CPR, I was a little bit hesitant. I felt that it would be very difficult to find something that would be internationally applicable. And the reason for that is that I started off looking at food composition tables from different countries and found that there was great variations in what they quoted as, say, the calcium content of different foods. And this is some of my early work where I was looking at cheeses to see if everybody usually quoted similar content. And as you can see from the circled foods, something like, for example, blue cheese, if you looked at data from the French or the American food composition tables, they had 50% more calcium in them than was quoted in the UK. And a similar amount for if you were looking at tin fish, which could be a measurement error. It could just suggest that tin fish in the other countries has more bone in it. We weren't really sure, but I did think, oh, is this going to be difficult then to make generalizations that are helpful? But one of the main issues that came up was that in the UK, we have mandatory calcium fortification of our flour, and that doesn't happen in any other country. So it does mean that a lot of our flour wheat-based products may have a higher calcium content than those from other countries. So we also looked at the calcium that could be provided from calcium-based phosphate binders and the percentage of calcium that they would provide. And this can be quite considerable. So, for example, if you had somebody on calcium carbonate 1.25 grams 3 times a day, that could provide 1.5 grams of calcium per day. And the importance of taking into account other sources of calcium was again borne out when we published our paper, where we looked at calcium intake in chronic kidney disease. And you can see from the pink box and whisker plots here that if you just took diet, that our children actually didn't have a great intake. So 76% had an intake below the UK suggested requirement for age. But when you allowed for the calcium that they were getting from medications, including the phosphate binders, but also some were on supplements, 177% is the medium we'd increased their calcium intake to. So there were very few that actually had an inadequate calcium intake when you took into account medications. So the statements in relation to this do suggest that calcium from all sources should be taken into account. So we then moved on to have a look at the suggestion for requirements. And we had a look at all of the publications we could find that suggested calcium and phosphate intake in childhood. And there was a considerable range of values, different derivations, different definitions used. And we really found it very difficult to pull them all together into one suggested amount. And so we decided to choose those who had the most reliable methods for assessing mineral status. And these are shown here on the table for calcium and phosphate. So the EFSA, the European Food Safety Authority, the German, Austrian and Switzerland levels, the Nordic Council of Medicine and the American recommendations. And we had a look at all of the values that were suggested for different age groups, the age groups in this table being shown in the yellow shaded boxes. And we did find that there were considerable variations. So this is just one of the examples I've pulled out where you can see that the calcium intake in similar ages would be 40% recommended higher in the using the American recommendations compared to the Nordic recommendations. And similarly, there were lots of other differences, such as the age ranges that were quoted for. Some took into account pre and post puberty, and some just gave a generalization. So because of these variations, we decided not to endorse one particular published values, but chose those that were using the most reliable methods and used an average of all of those quoted ranges to come up with this term suggested dietary intake. And the suggested dietary intake assumes that normal requirements follow a normal distribution, and that if we took the mean plus 2 standard deviations, that would cover 97.5% of the population requirements. And that is our SDI. So we've used the internationally published values as our limits for the SDI, and we really hope that people start using these for assessing the adequacy of diets, and also to allow so many more international comparisons. And this is going to be really helpful, I think, as we move forward in the research field. So just to show you the SDIs for calcium and phosphate across different age groups. For the younger ages, you can see we weren't able to quote a range because a lot of the bodies don't quote requirements. They assume that breastfeeding or infant formula will provide adequate calcium and phosphate. There was a proviso that if a child has poor growth, that it's best to use height age, and height age is the age that corresponds to their height plotted at the 50th centile on a growth chart. And just to show how that is in practice, if you have here a 4-year-old and their height is on the 2nd centile, if you come back to see at what point their height would be on the 50th centile, that would be about 2 years for this child. So their height age should be 2 years, and you'd look at the requirements for that age rather than their chronological age. So the CPR suggested that we should regularly assess for total calcium and phosphate content, be aware whether phosphate additives are present, even though we can't quantify them, and that the frequency of these assessments really depends on the child's age, their chronic kidney disease stage, and also their biochemistry. And we suggested that we aimed for a calcium intake with and up to 2 times the upper limit of the SDI, maintain the phosphate intake within the SDI, and limit phosphate additives. So the research recommendations that were part of the clinical practice recommendation are very much in line with some of the problems that I've highlighted. So the first one in relation to intake and phosphate binders, we really need studies to understand how much calcium is absorbed from these calcium-based phosphate binders in those with chronic kidney disease who are vitamin D replete. We need to know a little bit more about the best assessment tools for dietary intake, perhaps comparing 24-hour recall with a 3-day diary, and then to get more information as to whether or not it is appropriate to base requirements on those of healthy children by having calcium balance studies of children with chronic kidney disease to decide on the right intake for normal bone mineralisation. So, as was mentioned at the beginning, the mission statement was very much to produce these clinical practice recommendations from the task force, but also to produce resources, not just for healthcare professionals, but also for families to be able to use. And this has gone ahead, and as you know, you have access to this practical guide for healthcare professionals as part of this webinar. And we also have the guide for children and families, which Per will be looking at in a lot more detail when we talk around the case study. So this practical healthcare professional guide suggests that care could be looked at in terms of steps. So we've summarised dietary management in terms of a flow chart, with step 1 being dietary assessment, step 2 looking at requirements, step 3 looking at some of the practicalities of management, 4 is monitoring, and 5 is the use of phosphate binders. And as you work your way through this practical guide, you will find that the beginning of it is just talking about the flow charts and the stages in that. But the next stages are all of the information which we think you need to manage children with chronic kidney disease in relation to calcium and phosphate. So we've included here a table of calcium content of food in relation to portion sizes. We've also left a table, as I said. You might have local values of calcium that you want to include here, and which are foods that are commonly used by your population, so that can be written in there. We've got the phosphate content of food, and we've tried to suggest by the shading for the red, pink and white that the red are those that are high in phosphate additives, the pink are less likely to, and the white are unlikely to contain phosphate additives. And again, a table for you to fill in. We've included the E numbers and names of the common phosphate additives that could be a problem and the foods that you might find them in. We've quoted the SDIs and the aims, and then gone through some of the practicalities in terms of food and fluid management, which we'll be talking about in a minute. The monitoring and the review in relation to biochemistry is listed in this booklet, and also we've then gone on to talk a little bit about the phosphate binders. So we really hope that you do find that a useful tool, and we're going to welcome feedback on that. So then to move on to our case study, we've chosen a 4-month-old male who's born at term with posterior urethral valves that were ablated early, a good urine output and a diagnosis of chronic kidney disease. And the anthropometry that you'd be doing, you'd of course be looking at weight, length and head circumference and plotting those on the WHO growth charts. And so for this boy, we've suggested that his length is a little bit lower than his weight and head circumference on the growth charts. And what I'd like you to do is work you through the steps in the practical guide. So step 1 is dietary assessment, which if you found out that this child was feeding a whey dominant infant formula at 130 mils per kilo, not having any solids, but having a vitamin supplement. So you could have a look at that. Of course, you would assess for energy and protein intake, but that isn't part of this webinar. So what you would be doing is thinking, oh dear, I need to get rid of that vitamin supplement because it's providing additional vitamin A, which we don't need because children with chronic kidney disease run high vitamin A, and that can contribute to hypercalcemia. You might then have a look at some data cards to assess calcium and phosphate intake, and I've done this here looking at one of the common whey-based formulas that we use within the UK. But if you just had access to the practical guide, you could have a look and see what a normal whey dominant infant formula would provide in terms of calcium and phosphate per 100 mils, and come up with a not dissimilar figure in terms of calcium and phosphate intake for this child. And then you could compare that to the SDI, and calcium is fine. Phosphate's a little bit low in this instance, but it might be that 130 mils per kilo is a bit of a low volume of formula for this child to take. So it might be that they actually work their way up to more like 150 mils per kilo. You might think, well, this is a short child. We really need to look at their height age, and you could plot that, and their height age would be nearer 2 months rather than 4 months. But I think it's probably less useful looking at it in these young children, because as you can see from the table, we would look at their calcium and phosphate SDI for their height age, and it would suggest that they were having a little bit of a high intake because there's no range at that lower age. So probably more appropriate to be looking at it for their actual age for these little ones. So in terms of step 3, which is management, we would move on to thinking about weaning or complementary feeding, and we could look at all the information that's available to us. This practical guide suggests exactly what you should be doing in introducing foods initially that are low in phosphate, like fruit and vegetables. If you're using cereal products, make sure they haven't got additional milk powder, which will increase the phosphate content, and then gradually introducing higher phosphate foods in a controlled way throughout the first year of life. And then moving on to the parent guide, parents can look at this and see, oh good, breast milk or whey dominant infant formula is suitable. And so they could know that the way that they're feeding their child is very suitable, considering their renal problems. And then in this guide, it says start with vegetables and fruit, then gradually introduce natural phosphate sources and avoid foods containing phosphate additives. So looking at what we've decided, we've done step 3, which is the management to limit dietary phosphates. We need to ensure adequate calcium as well, as Roxana has stressed so much. And so carrying on with a formula that's low in phosphate but high in calcium, such as a whey dominant infant formula, may be necessary even way beyond the first year of life, particularly if a child likes to take formula milks, and or you can consider a calcium fortified plant-based milk, providing it doesn't contain calcium phosphate and contains calcium carbonate as its calcium source. The step 4 is the monitoring and review. And the important point to say here is that make sure you are looking at age appropriate reference levels. And as you can see from the chart over on the right, at different ages, higher phosphate levels may well be normal. And so it's important not to jump too early and to be looking at the levels that are appropriate in your lab for the particular age of child you're dealing with. Now, for the purpose of this webinar, I've put these biochemistry ranges and results such that this child has a high phosphate, a high PTH, a low ionized calcium, and normal vitamin D. So if you referred to your guide, you'd think, well, I've got to limit phosphate intake to within the SDI, but you've already done this. They were already on a low phosphate intake. So you'd need to start phosphate binders. And you would go to step 5, which is the advice in relation to phosphate binders, and use a suitable preparation that you had available. We have up until recently had a calcium carbonate product that was easily dispersible and very suitable for this use. And so we would have used like half one of these tablets in each feed, which could provide 200 milligrams of calcium. So you still need to think about your calcium. The total calcium intake from the formula and from the binder would here be 630 milligrams of calcium for the day, which compared to the SDI, remembering that we can have up to 2 times the upper limit of the SDI, we can see that that calcium intake is absolutely fine and that they can cope with those phosphate binders. So I'm now going to move on to Pearl, who's going to discuss the progression of diets and how to use the family guide in more detail. Thank you.
So let's build upon this case study that Louisa's expertly started with. So we've got a young child that's growing and has now reached 18 months of age. And as we've said already, the important thing is we work through each of these steps. We need to be regularly reviewing, and the importance is we don't look at single values, but we're looking at the trends of calcium and phosphate over time. And this will change, particularly with the change in their CKD status, the change in any treatment, and particularly their dialysis modality. So we know that we're dealing with a hyperphosphatemia state and a high PTH. So our priority is to really try, we've already done a little bit, but we need to review again to look at what we can do to try and limit this child's intake of phosphate to within the SDI. And this accounts for, so if we're looking at the DOKI guidelines, this comes out at just the lower end of the SDI, which is equivalent to 80% of the DRI. So in addition, we've got a picture of a low ionized calcium, and our vitamin D needs addressing as well. So we're wanting to really make sure we're giving adequate calcium. And so we can look at what this individual child's picture is like. We may need to consider adding additional calcium as the supplement, and also looking at their vitamin D and whether they're getting sufficient. So this may involve looking at some vitamin D analogues, either calcitriol or looking at their current dose and reviewing their dose of alpha calcidol. And we mustn't miss out the amount of calcium that's coming from their dialysis fluids. And it's important to speak with your dialysis colleagues to see whether there's an approach to manipulate the amount of calcium that the child's receiving during dialysis. So we've got our table, which I'm sure you'll find really helpful, just as a quick guide to have a look at some of the key sources of phosphate, but more importantly, the bioavailability. So it's so key with these children that we're really focused on early on is trying to reduce those foods that have got a very high bioavailability, so between 90 and 100%. So both of these have it. Now we know those in the red section are almost certainly going to contain phosphate additives, but those in the pinky section may contain it, and that varies depending on the different type of product. And as Louisa said already, manufacturers are not obliged to list it. So we can assume that a significant number of processed products will have some phosphate additives in them. And then we know that those products that naturally contain them, these are like your animal source. So they won't have any added phosphates from phosphate additives, but they'll be naturally bound. And so the important thing here is to be aware of what the source is. So in animal sources, the phosphate is bound to carbon, and that requires enzymatic activity in the gastrointestinal tract in order to release that phosphate. And that's quite a slow process. And so the phosphate that's released slowly from these animal-based sources has a lower phosphate bioavailability. So it's still there, but it's reduced the rate and the amount that actually is available to the child. But the plant-based sources, so even some of these where it's actually coming, so I'm particularly thinking here, I guess there's a growing number of like vegan processed foods. And some of these foods may contain phosphate additives. So we can assume that the phosphate additives will have up to 100% bioavailability, right? But there may also be some phytate present, and that's the fiber that is actually used as the main storage for these for the phosphate. And so if there is phytate present in some of these vegan products, then the amount of fiber that's released is minimal, because we don't, as humans, we don't have phytase, and so we're not able to break down these little storage capsules and release the phosphate. So the bioavailability from these plant foods is actually really, really quite low. So it's just these vegan products can be, we often class them as like a moderate source of phosphate because we don't exactly know how the phosphate is contained within these foods. But the foods that we know have got a very low bioavailability are the plant-based foods. So just to reaffirm, we're really wanting to cut down on foods that have got lots of phosphate additives in them. We know they're put there for genuine and legitimate reasons, but it can increase the dietary phosphate load by up to 50%, if not more. And they're used for many, many reasons, but a diet that's mainly based on fresh food, where we're not using processed products, will contain some natural phosphate. As I said, it's slowly released in the GI tract, but the bioavailability is much lower and it reduces the phosphate dietary load. So again, looking at the calcium, so this really handy table will give you an insight to just the calcium content in some popular foods. So again, just reminding that in the UK, white bread and flour is fortified with calcium. So this can actually really be beneficial. And this comes into play when I look at this child's diet history and about the decision that I make here. So I'll go into that more detail just in a moment. And then cow's milk. So it's important to realize whether you use whole, semi-skimmed or skim milk, they still have the same calcium and phosphate content. That doesn't change. If we're using a plant milk or a non-milk based pudding, such as the soya yogurts, they may be fortified with calcium. So that can be a really helpful tool if we're really struggling to get a child's calcium intake up. And then just thinking about some unusual foods that you might not even be aware of got a lot of calcium in them. So things like curly kale is a really easy thing to blend down and put into the weaning diet or add into a toddler's diet. So it's a really rich source of calcium. Also, things like baked beans can really be helpful in contributing to the dietary intake of calcium. Things like figs, ready-to-eat figs, are a really rich snack. And also orange juice is fortified with calcium, but we really need to be mindful of how these can contribute to the potassium load. So we need to look at the bigger picture of what's happening. So let's look at the nitty-gritty here. So I've taken a diet history. So I did a diet recall from the parents of this 18-month-old. And you can see that they start their day with a glass of cow's milk. Sometimes they have water, other times juice. And then they have a refined breakfast cereal, often chocolate balls with some cow's milk. At lunchtime, they might have some beans on toast or some scrambled egg with some grated cheese on. And that's on wholemeal toast with some butter, a small packet of crisps, a small little petit falou yogurt, and then they have some crispy chicken pieces for their evening meal, accompanied by potatoes, broccoli, and some satsuma. So I've calculated there and just done a guesstimate to work out using the table from the CLP, from the guide, the healthcare professionals guide, and it'll give you can see the quantities there. So I'm just highlighting here some key factors. So we know that they're baked beans. I've got fiber, so their phytate content, and also in wholemeal toast, the phytate content will reduce the bioavailability of the phosphate. And we also know that processed chicken is going to have a really high bioavailability there, the phosphate. So how do we compare here with our SDIs? So we can see that let's look at the calcium first. So the calcium, we're giving about 865. So we're just above the SDI, and its recommendation is that we either do within or up to 2 times the SDI. And then for phosphate, we've got 865. So we're way above. We really, really need to just see if we can bring this dietary phosphate down significantly. So let's see what we can do. So that's our starting point. And then we need to try and make some changes. So as we've said already, one of the richest or the main contributors to both calcium and phosphate in the diet is often dairy products, so milk, cheese, yogurt, eggs, and then cereals. So we can see here, we can start with the breakfast and we can look at changing that cow's milk to either a whey-based infant formula or a plant milk. We may use water or juice, but the thing is not to compromise on the calcium intake. And also it's really important that we're very aware that many plant milks are low in calories. And so it's really making a clinical judgment on what's the best option for your individual patient. So I've chosen here to actually use 200 mils of a whey-based infant formula. Now you might say, well, this is an 18-month-old, why are you using that? But we often in practice will continue to use a whey-based formula way beyond the recommended period, if that seems to be the best approach for that child. So you can see we've cut the phosphate down from 200 to 64 milligrams in that total 200 ml volume, yet we've maintained a decent calcium content. And then here we've got the refined cereals. Now, you might question about the whole grain cereals. So we know that the amount of fiber that's in whole grain cereals is quite high. However, the bioavailability is lower. So the net amount of phosphate that's absorbed is probably similar to that in like a refined cereal. So I've here, and particularly a refined cereal that's got chocolate in it. So I've gone here for a whole grain breakfast cereal. Now you may choose to go for something like cornflakes or Rice Krispies, but a really important thing that I think we're becoming more aware of is the importance of fiber in the diet, and particularly in children, not to give too much, but we need a sufficient fiber intake, particularly to promote the good gut microbiome. And then we've got 100 mils of a whey-based infant formula again. And then moving towards lunchtime, I've chose to keep with beans on toast, but I've swapped then the type of cheese to a vegan-based cheese. Now this is very individual. Some individuals really don't like this. I think they're actually becoming much more palatable. So I've tried quite a number, and I contacted one of the companies recently just to get a most up-to-date composition of what's in them. And their phosphate content is absolutely minimal, And sadly, they don't actually fortify them with calcium, because actually they really don't have calcium in them at all. So it's really minimal. So that's a key concern here with some of these the vegan cheeses. And then with the white toast. So you might say, why have I done white toast here? Well, as we've identified earlier, flour is fortified with calcium. And I really want to optimize here on the amount of calcium that this child is getting. So I could change to a wholemeal bread, and that will, reduce the amount of phosphate, the net reduction of phosphate overall because of the bioavailability. But if I went to a wholemeal bread, I would lose the amount of calcium because the calcium content in the wholemeal bread is lower. So I've kept the white toast here with some crisps and then some jelly. So I've swapped the small yogurt for jelly. And you'll see later, to make the diet more flexible, so it's not too rigid, there's a tool that you can draw upon in the parents guide and also in the healthcare professionals guide that gives you a swap list, and it helps parents to see, well, if I don't want to use a small yogurt one day, what could they have instead that's got the equivalent amount? So I'll just draw upon that in a moment. And then we've changed from processed chicken pieces to unprocessed chicken. And accompanied by the same potatoes, broccoli, and you can see that that's contributing a small amount of calcium there. So let's see how we're doing again. So here we can see that we've now got let's look at the phosphate here first. So something that's really important here, because we've managed to bring the phosphate right down, so our phosphates come right down now from 865 to 346, which is the lower end of the SDI. And so it's questionable now, do we actually need phosphate binders? And that's a clinical judgment that you need to make with your team, and also just looking at those serial measurements of phosphate to see whether the trend is consistently staying within the normal range, because you might manage to, it does happen, you can control it just with diet alone, or you may need to add the phosphate binder. But if you choose to drop that phosphate binder, you need to be aware that you're losing some calcium there from that binder. So that's just a question mark there to just consider the impact of the phosphate binder. So if we're not getting that calcium from the phosphate binder, then the calcium intake of this child now is actually really quite compromised, and I would be concerned here, and I'd really want to be considering whether we need to be giving a calcium supplement. Now we are hitting it with the phosphate, we're managing to get that down. So we would look at maybe considering for a short period of time, we might want to give a calcium supplement, but we do need to regularly be monitoring that. So the phosphate's within the SDI, the calcium intake is within, but it's at the lower end, and we want to really build that up. And we may need to then review their vitamin D to make sure they're getting a good absorption of their calcium, and also consider again the calcium from the dialysate fluid. So this guide for families, I'm just going to take you on a very whistle-stop tour just to show you what's inside it, and I trust it will become a useful tool for you as clinicians. So it starts by giving you an overview of why we need to be looking at phosphate and why we need to be limiting it. And then it really shows you just in a stepwise direction where it's coming from. So from the natural organic sources or the inorganic sources, and it just highlights some of these key sources and gives you just tools on how to go about trying to limit those phosphate additives. And then it highlights some of the key sources, but as we've said, so some of the key phosphate additives, but I wouldn't rely on looking for a lot of these names on the labels because the manufacturers are not obliged to list them. So you can get parents tuned up to looking out for them, to looking for that term phos, and that will really tell them it's there. But even if it's not in that list, that doesn't mean that that product doesn't contain it. So we really are working in the dark here. It's not an easy situation. And then we're looking at those foods that are naturally rich in phosphate. And we know the bioavailability is lower, but we need to be aware of how much they're having of them. And then we've done this color-coded traffic light system. So it will help you to really flag up the very rich sources containing phosphate additives, those containing natural sources, and then the green one, the green column that has got lots of alternatives that are lower in phosphate. And then you can see that briefly, but I'll expand that later to look at the swap list to give some flexibility in the diet. And then some key tools, which I'll go through in a moment, about phosphate binders. So this is a new resource that's soon to be released, and this is a phosphate tool. It's an interactive tool where families can tailor it to their family or their child's intake. So it allows them to use this traffic light system. And if I just show you how we can tailor it, here we go. So it allows us, so if we hone in on the lower phosphate sources here in the green. So I've just put in, obviously for my child's diet, we know that we don't want them to have those processed chicken pieces. We want to highlight some good options when it comes to meat. So we've put in here unprocessed meat and chicken as well. And then we can also fill in all the make bespoke lists and just fill it in and tailor it to their individual requirements. So within the dairy, within the different categories, and likewise in the foods that are naturally rich in phosphate. So I've put in here some of the cheese and the yogurt, and then I've highlighted here, we've put in some of the dairy products which are really rich in phosphate. So this is just a tool that I think could be a really helpful interactive tool that can be updated. So if your diet changes or you're trying different recipes out at home, then they can update this and print these off and maybe put them on the fridge as a useful guide at home. So this swap list is a really useful little tool to have available. So it just gives them the option to say, well, instead of having a small pot of yogurt, they might want to have a small slice of pizza one day, or they can swap, say, a small pot of a probiotic drink for maybe 2 small scoops of ice cream. So it just gives that permission to be flexible so that they're not going over on their phosphate content. So the important thing here, so now that we know that we have to look at that individual child, but we need to see if there's a requirement for a phosphate binder. I'm just going to go through the important factors. So as I said, in our case study, it was questionable whether they needed a phosphate binder, but that's something that we really need to make that clinical judgment on. So the important thing is we tailor the phosphate binder to the diet and not missing out on the snacks. We need to be mindful that not all foods require phosphate binders. And if they're on a nasogastric or a gastrostomy feed, we need to tailor it to the best timing. So it might be mixing it with the formula or the feed, or adding it at the beginning, during, or the end of the feed. And we can see there, as has already been shown, that there's a variability in the amount of calcium that's absorbed from these different binders. So the important thing here is that we really want to support you in better managing your child's phosphate. And we've provided lots of really useful resources, which I hope you'll find really helpful. So we need to prioritize initially by limiting their intake of phosphate fluids, looking at what alternatives we can give so we can really cut down on the processed foods that are being given as part of the weaning diet, and also the toddler and the young child and the older child's diet. Educate more about where the phosphate is coming from and the huge change and variability in the bioavailability. We need to be looking at what their natural sources are, and there may be a point where we need to cut those down in a measured way, but only after reducing their phosphate intake, reducing their processed food intake. And then we need to really support them, because we can't just keep saying, cut this out. We need to provide some good recommendations of alternative foods. So that food swap list gives them that flexibility. And then we need to tailor it, tailor any binders that they require. So I've just given here just a reminder on the swap list, and then the different interactive tools that we've got. Now we need to make sure that we're keeping that calcium level within an acceptable range. So the key message is throughout the whole of this is that we're assessing, we're managing, we're monitoring, and that we're regularly reviewing.
Thank you, Pearl and Louise, for that very good illustration of the guides and how we can support families and health professionals with patient management. We've just got time for a few questions, so perhaps I could just start off with Roxana. We've been talking very much about making sure there's adequate calcium, but what happens at the other end of the spectrum in the case of hypercalcemia? We know that a reduction in dietary calcium might be helpful. What are the key aspects of the medical management in a state of hypercalcemia? And what would you consider severe hypercalcemia?
Very good questions, Vanessa. Thank you. So we've covered this in our guideline. We didn't have a chance to say it today, but essentially the management of hypercalcemia is largely medical before one needs to make dietetic adjustments. With the medical management, keeping in mind that vitamin D analogs can increase the absorption of calcium of gut calcium from just 20 to 30% to as much as 60%. My first step would be to stop all vitamin D supplements completely. So this includes native and active vitamin D. I'd then carefully look at other sources of calcium. Some children may be on a high calcium dialysate. Some may be receiving other medications containing calcium, such as, for example, calcium resonium. So this needs to be looked at thoroughly. And after reducing the calcium intake and reducing its absorption, if the hypercalcemia persists, then of course we need to look at other aspects, such as the dietary intake and whether that needs reduction, and also whether in fact this is calcium being driven out of the bones and you need medical management, say with a bisphosphonate to control it.
Thanks very much, Roxana. And there is a case for temporarily stopping all dietary input of calcium.
I would say this is perhaps one of the last steps. I wouldn't do it initially because its impact may be lower than actually reducing the exogenous intake from medications and the dialysis fluid and the absorption, and the absorption with vitamin D.
Thank you. And Louise, at the other end of the spectrum then, how can we ensure enough calcium is going into the child? You have mentioned the phosphate binders. Do you find yourself often in a situation where you're having to give supplementary calcium?
I wouldn't say often, but I do think it's something that we need to consider more, because you are often limited, and if you are cutting back on those dairy sources of calcium, you could look at a lovely table of where you could get calcium from, like curly kale or something, but in practice you've got children with a very poor appetite, and so some of those sources may not be things that they would naturally want to have.
Thank you. And along a similar theme for Pearl, please, you've spoken about how a plant-based diet can be beneficial from the point of view of the phytate binding phosphate, but doesn't have a counterproductive effect then on calcium, because calcium absorption would be inhibited by a high phytanic acid load in the diet?
Yeah. Absolutely. So that's something to be really mindful of. We might be gaining in terms of a reduced bioavailability of the phosphate, but we really need to be aware of the fact that they're not going to be getting a good absorption of calcium. So it's important that we look at alternative sources of calcium in their diet, particularly like in a vegan diet, definitely.
Thank you. I'm just having a look at another question here. This is probably for either Louise or Pearl. Do you ever consider reducing the dietary phosphate intake to below the SDI? And what are the consequences of giving too little phosphate?
So we often find that we're giving a low amount, particularly in the very young children, if we've got them on specialized formulas. Sometimes we find that their phosphate intake might be significantly low. So we just regularly review, and we'll then maybe look at a different combination in their feeds. We might change the type of the composition of their feed to make sure that we're increasing the amount of phosphate that we're giving, because we really wouldn't want to compromise their phosphate intake.
Thank you. And
I was going to say, I think that's,
yes.
Yeah, I was just going to say, I think that's where you have to be MDT working. So to understand that we can perhaps say some of the practical guidelines, but to understand it within the whole context of CKD, MBD. And we have had children on phosphate supplements, even if their phosphate intake was low and their biochemistry was interpreted as suggesting it was insufficiency.
Thank you. And you indicated that phosphate binders could be added to feeds. Do you ever come across problems with the ingredients of the formula settling out with certain phosphate binders, and which ones would be problematical?
So I can comment that in practice, we haven't had any experience where parents have told us that it's caused the feeds to separate. But I know in the literature, it's definitely something that is documented, and certain binders have been known to cause that separation or to block some of the tubes if they're not flushed adequately.
Is there anything you'd like to add, Roxana? Sorry, Roxana, first of all, anything to add on that?
Yeah, I absolutely agree with Pearl, of course. The only thing is with calcium acetate, it doesn't dissolve as well as calcium carbonate, and especially when it is added to, say, a 24-hour preparation of the feed or an overnight feed where, say, an overnight bag of feed is hung up, then it does tend to sediment at the bottom. Our advice to families is to frequently shake the bag to try and dissolve it and spread it throughout the feed in a more balanced way. But calcium acetate certainly can do that.
Thank you. Louise, did you want to add something?
I was just going to say, we also have just done tabletop tests with different feeds, putting calcium acetate and calcium carbonate in it, just to see what would happen. And some, I think it's more the ready-to-feed products, some of them have almost curdled, that isn't the term, but separated out when the calcium acetate's added to them. So I assume that that would also be happening within the stomach and the gut. So it can be quite dramatic. So if you have any worries that that is happening, then actually just try a test before giving it to the child.
Thank you. And Pearl, for the breastfed infant, any tips on controlling phosphate in the breastfed infant?
So, I mean, the approach we take here is we're really pro, obviously, as dietitians, we want to encourage breastfeeding. That's the best approach for any child. It can be a really anxious time, I think, when a mother has a child that's just been diagnosed with chronic kidney disease, or they've had that diagnosis, it's going to be quite a new diagnosis, isn't it, if they're still breastfeeding. And so, some would say you can encourage the mother to be mindful of what's in their diet. We wouldn't take that approach because that very much adds to the anxiety and the burden of care for that mother. So I think we can look at, from practice, the profile of breast milk is actually not that different to some of our specialized infant formulas. So it's actually almost, it's like a renal feed. And so we would just be looking at their, serial measurements. We'd be wanting to make sure that, we're doing what we can. If we're running into a problem where their biochemistry is starting to rise, then it might be a point where we need to introduce a different feed, but continue with some express breast milk if possible. And it's just working with the mother, working with the team and deciding together what's the best clinical decision for that individual child.
Thank you. And for Louise, for a child who has poor intake and they're reliant on gastrostomy feeds, would you still use a whey-based infant formula in the older child? From the point of view of the phosphate, presumably.
Yeah, yes, that might be suitable, but we're getting quite adventurous now in that we're looking at any formula, even if it were meant for perhaps an older child or even an adult. If you've got a fluid restricted child, it might be that another formula is suitable. But certainly our history is that we always are thinking that we could base it on a whey-based infant formula right up until 3-4 years of age. But some of the paediatric formulas that are around are pretty practical to use. So you have to think of that as well. But it is just doing the calculations on what you have available and thinking what's the most practical for the family to do as well.
Thanks. And we have had a question about what to do if you don't have specialist formulas available in your own country. And just to say, that's another piece of work that the task force is going to be doing for making these practical guides relevant for local practice. And that's the next phase of our dissemination project. So keep a lookout, because we will be looking for vanguards in each country to help us develop these practical guides and family guides so that they're suitable for your local population. We are past time now. We probably should wind up, but I just wanted to give Rakshana an opportunity to make any comment from the medical aspects before we wind up.
Thank you very much, Vanessa, and thank you to Louise and Pearl for fantastic talks, beautifully illustrated examples, and we really hope it's been helpful for everyone. So I do very firmly, even as a medic, I do very firmly believe that the initial management is with dietetic management, and the medications follow on from that. It's not either or, it's supplementing each other, but you cannot ignore the dietetic side and just add on a whole bunch of medicines. That never works. So we hope this was helpful for everyone. Thank you so much. I think we just have to announce our next webinar now, and perhaps Lucy is going to do that for us.
Brilliant. Yes, thank you. And again, I just echo that really. So thank you so much for our speakers today for such a comprehensive presentation. So you may remember that at the start of the webinar today, we mentioned that this webinar forms part of a series of webinars by the task force. So on this slide, we highlight the webinar schedule for the next 6 months by the task force. And again, each webinar will cover a specific area of dietary management. So on behalf of VitaFlow, we would like to thank you for tuning in today, and we hope to see you at the next webinar, which is focused on the dietary management of potassium on the 13th of July. So please do take the time to complete the evaluation questions before you leave today and to download your certificate of attendance. So thank you everyone for joining us, and goodbye, and please enjoy the rest of your day. Goodbye.
Bye.